Hi there, guys. My name is Kyle DeMello. I'm a PGY2 here at UT San Antonio. I'm finishing my EMS block up and wanted to give you guys a presentation on something that I think is pretty important, the QT interval. I think when looking at EKGs, it's something that we forget a lot to look at, and we don't realize all the implications that it can have. Hence why I call this the quiet culprit. On EKGs, whenever we get them, we tend to jump to kind of some of the bigger things. We look for, is there a STEMI, is there no STEMI, is there AFib, what the rate is. Maybe if we're getting into more fancy kind of things, we'll look to see if they have a right bundle branch block, left bundle branch block, stuff like that. But we really neglect the QT interval, and I think as this presentation is going to show, there's a lot of reasons that we should look into it a little bit more. Okay, so we can start with what is the QT interval. It is the measurement from the beginning of the QRS to the end of the T wave. This means we're going to be looking at ventricular depolarization all the way to repolarization. So the interval is looking at when the ventricle fires all the way to when it fully relaxes. Um, with this, you may have also heard the term QTC. It usually comes on the top of the EKG as well. This is very similar. The only difference is it's trying to standardize the QT based on a heart rate of 60 beats per minute. So it's trying to account for variability in people's heart rates. Technically, if you look in a textbook, you can see an abnormal QTC is going to be like 440 in males or 460 in females and above. But usually we don't really worry about the QTC until it's above 500. So here is just a slide showing all the intervals. If we look to the right, we can see the QT interval. Again, we can see it starting at the beginning of the QRS and finishing at the end of the T. An EKG is going to give you the value for the QT and the QTC. If you ever think it could potentially be off, you can always measure it yourself by just counting the boxes from the QRS to the T wave. Another shortcut to looking at the QT interval and making sure it's not prolonged is to look at the RR interval. It's looking at the two peaks of your R wave and then drawing a line right through the middle of the halfway point. Your T wave or the QT interval should be completed before that halfway mark of the RR interval. And if not, then you know that the QT is most likely prolonged. So here in this slide, if we go halfway between our RR interval and draw a line out as best as I can, we can see that the T wave or the whole QT interval is done before that line. And thus, we can assume that the QT interval is not prolonged in this EKG. This slide demonstrates a good view of a prolonged QT. We can look at this last rhythm strip here at the bottom. If we use our trick again of finding the halfway point between two of the R segments, we can draw a line, be somewhere around here, and we can see that the QT interval does not finish before that line. Thus, we can assume that the QT is prolonged here. So why does this all matter? The biggest, most important, most emergent consequence that can occur with prolonged QT would be going into torsade de pointe. Here's an example of that, the rhythm that you will see with the twisting of the points. That is, of course, not very common, but is the most deadly complication of prolonged QTC that goes untreated and continues to be prolonged. Another thing that we can think of, though, is syncope. Syncope is something that's a pretty common complaint, and looking at the intervals in general can help kind of solve some of the question marks when it comes to syncope. For example, we could find things like Wolff, Parkinson, White. We can find things like complete heart block, and QTC prolongation is just another thing on the list that can lead to syncope. Talk about torsades, this brings us into a good point of also talking about the QT nomogram. So this line that we are seeing here in this graph demonstrates the risk of patients going into torsades. Anything above this line, any QT interval above this line, shows an increased risk for torsade, while anything below this line shows that there isn't too much of a risk of the patient going into torsade. So we already talked about the QT and the QTC and how the QTC tries to standardize the QT with the heart rate of 60 beats per minute. If we just look at the QT interval itself, we can also see its relationship to heart rate here. And we can see that as the heart rate increases, the QT interval has to have smaller numbers to potentially induce torsade in a patient. So tachycardia with QT interval prolongation at lower increments are more of a danger to go into torsade. And again, anything above this line has a patient for increased risk of going into torsade. So how do people have prolonged QT? A few different things can cause it. For one, it can be congenital. People can be born with just always having a longer QT interval. Other things that can cause it, if you think a lot of the hypos, you can look at electrolytes, so hypokalemia, hypomagnesemia, hypocalcemia. Hypothermia can also cause it, along with other things like cardiac ischemia or raised intracranial pressure. One big thing, though, that I want to talk about a little bit more is medications, and we'll talk about this a little bit on the next slide. So here's some lists of some of the common drugs that can prolong the QT. As you look through the list, you might notice there's a lot of drugs that we don't even think about that can cause some of these side effects. A lot of drugs that we give, but also a lot of drugs that we'll find on patients' medication list. Things like amiodarone, for AFib patients. You see antimicrobial agents like the macrolides, fluoroquinolones, antifungals, antidepressants, antipsychotics. Even antiemetics, things like Zofran, metoclopramide, all make this list. And I think it's important to kind of have an idea of this list because if you think about it, we give some of these medications very easily when patients have complaints. They complain of having nausea. How easy is it for us to pull 4 milligrams of Zofran and give it to them? You might deal with a psychotic patient or an agitated patient, have to give them droperidol or Haldol, or maybe even a B52 combo, which involves Benadryl that also prolongs the QTC. So, it goes to show that we should probably take a better look when we get an EKG of looking at the QT interval and kind of trying to avoid some of these meds if their QT is in fact prolonged. Now, this isn't to say that if you give someone 4 milligrams of Zofran and didn't look at their QT right away, and it was prolonged, that they're going to automatically go into torsades. Giving a dose isn't always going to hurt them, but it's something that we should just be more aware about. If someone does have a prolonged QT on their EKG, it's best to avoid these medications if we can. You can always call into the hospital, kind of get some other recommendations to avoid prolonging the QT any further. So now on to treatment of prolonged QT. So the first thing is identifying the underlying cause. Is it one of those hypo conditions that are causing it? Hypocalcemia, hypomagnesemia, hypokalemia. If so, repleting that electrolyte is going to help improve their QT interval. Maybe it's hypothermia, then warming them up is going to help. Whatever the cause, it's important to go back to that previous slide and avoid giving those QT prolonging medications. If we can prevent prolonging it further and we can fix those underlying causes, it can start resolving. If it's not resolving, we can start with MAG. If they're not in torsade, we can give 1 to 2 grams of MAG and push it through. If they're into torsades, we're really going to have to be more aggressive, starting with 2 grams of MAG, waiting for a minute or two. If not improving, giving them another 2 grams, and then potentially even starting a drip. I suggest that if you get to the point of needing to use MAG, you consult, the medical director to try to figure out exactly how much to give, and they can keep an eye on the patient as well. It's important to note, too, if they do go into torsade and they lose pulses, we will defibrillate the patient. And then just some other things that they can do once they get into the hospital. can give isoproterenol, can do overdrive pacing, can even start the patient on a lido drip. So there are more options again once they get to the hospital setting. Thank you guys for watching the presentation. Hopefully you guys learned something with the QT interval, and hopefully you guys can take the slides and use them as reference when needed when encountering this issue in your ambulance rides. Thanks for a great rotation, and definitely ask any questions if you ever have any. Thank you guys.